So what we're going to do is basically talk about some of the indications for cardiac CT. So for those of you who are already involved in cardiac CT, it's really just a refresher of how you can use CT in addition to just looking at the coronaries. And for those of you who are relatively new to cardiac CT, it's how best you can use the modality to help you in your day-to-day management of patients. So whenever you are starting a service, it's always helpful to look at the various recommendation documents. So there's American recommendations, there's European recommendations, and obviously there's the NICE guidelines. I think the NICE guidelines are about to be updated, aren't they? So the most recent of these is probably the ESC and the AHA multimodality applications. So one of the first questions that you have to ask yourself is, obviously you've got this new technology. How are you going to use this technology? And probably the hardest question when you first start is, how are you going to use it together with the existing techniques that you've got? Obviously, most of you are in centres where no doubt there'll be either stress echo or SPECT or stress MR. And one of the questions that we always get asked is, how are we going to develop a service which isn't effectively competing with existing services? Because obviously what you want to do is to use the modalities in a way that are complementary rather than competitive to one another. And the way to do that is obviously to try to identify a group where you're going to get the best answer for the clinical question that you're offering. So in terms of the asymptomatic patients, obviously you've got calcium scoring and you've got CT angiography. I think in terms of your calcium scoring, there's more and more data to suggest that calcium score is a very useful adjunct to the traditional cardiovascular risk factors. So in other words, where it can be particularly of use is in the intermediate group. So if you look at people's cardiovascular risk based on traditional risk factors, you may find that on the basis of being in the intermediate group, they may not require therapy, but rather they should be undergoing things like dietary changes and also lifestyle modifications. By using calcium score, you can potentially identify a group that's of higher risk. And I draw your attention to this paper, which has recently come out, which basically looked at reclassification of people who are in the intermediate risk. And they found that if you apply the reclassification as recommended by the AHA now, you effectively double the number of patients who would require statins compared to who are receiving at the moment. And what they then demonstrated was you could sub-select this group further by doing a calcium score. And in those with a calcium score of 0, you can potentially carry on avoiding statins, whereas those with a high calcium score of non-zero, those would benefit from more aggressive therapy. So in other words, it helps you rationalize your therapy. But clearly, if somebody's high risk, they're high risk, and the calcium score arguably is not going to add much more to their management because you're going to be treating them aggressively anyway. So in terms of CT angiography, if we look at some of the data out there, certainly this paper was in 1,000 asymptomatic self-referred patients. In terms of your pickup of significant stenosis is relatively low, and also in terms of outcome measures, it doesn't actually change the outcome in the majority of patients. So in terms of offering CT angiography as a screening test for the asymptomatics, it's probably not justified based on current data. And you'll end up in a similar quandary to the FAME study, whereby you're effectively then left with a potentially significant stenosis in a patient who's asymptomatic. Obviously, if it's surgical disease, then it makes it much easier to manage. But in non-surgical disease, a significant stenosis in an asymptomatic patient is a quandary at the best of times. So the data would support you not doing CT angiography in asymptomatic patients. So if we look now at quite a large database from the CONFIRM registry, that basically underscores the same principle, which is, although you will pick up patients with significant stenoses, in terms of the outcome, you're often not changing the outcome, and moreover, the amount of patients you're picking up compared to the amount of patients you will be screening are quite disproportionate. So you'll end up putting loads and loads of resource into identifying a very small percentage of patients. So in summary, in the asymptomatics, there's no evidence of improved outcome with intervention, as you know, and it's a similar problem with CT angiography. There is some data to suggest that in patients that are very high risk, so for example, in patients with a very strong family history or in diabetics where you know that symptoms may not be typical and may even be absent, then there may be an argument for screening these patients. But at the moment, the data would support not screening asymptomatics. So in terms of your symptomatic patients, much easier. Obviously, what you have to consider is who best to screen or who best to perform CT angiography in. So the most important message, hopefully, that you'll take away from this lecture is CT angiography is really a rule-out test rather than a rule-in test. So where CT angiography gives you the most reassurance is in tests that in patients that do not have significant stenosis. You'll see during the course that there's lots of technical issues with plaques and plaque analysis, and often we tend to overestimate degrees of stenosis when you compare them to angiography. So in other words, the specificity of CT angiography is relatively low compared to the sensitivity. So in other words, if you have got a normal CT coronary angiogram, that's very, very reassuring. In the same way that if you don't have a significant stenosis on CT angiography, again, that's very, very reassuring. So effectively, what you're trying to identify is a group of patients where you can say to them, you do not have significant coronary artery disease. So in other words, you can then discharge those patients, yeah.
So for the negative predictive value, what do you mean by significant coronary artery disease?
Well, what I'm saying is potentially flow limiting by significant. So obviously you will identify a group of patients, and we'll come to that when we talk about prognosis. You'll get additional information as to their atherosclerotic burden, which obviously is important. But in terms of identifying a group with potentially flow-limiting disease, which if you look at some of the studies, some of them define as greater than 50%, because 50 to 70%, as you'll come to understand, is a grey zone with any anatomical imaging, be it angiography, be it CT angiography. So a lot of the American studies use that 50% as a cutoff for what they classify as significant versus non-significant. Obviously, it's arguable, because some people will say, well, it should be more than 70% before you say it's significant. But the point is, if you've got less than 50%, you know, your chest pain is not going to be coronary in origin, and therefore you can potentially discharge patients. Ultimately, again, if you're thinking about structuring a service, what you want to do with non-invasive tests is be confident in discharging patients who do not require further investigation, or at least invasive angiography. The idea is, if you think about it, when we do a stress echo or when we do a stress MR, you know, if it's negative, you often discharge the patient. Where CT angiography has the advantage is it will give you much more information as to the overall atherosclerotic burden. So you'll be able to separate patients who've got normal coronary arteries from those who've got non-significant stenoses who will still need aggressive secondary management, secondary prevention. So this data is basically from multi-centered trials, so it shows that it's quite reproducible. Obviously, whenever you look at data, it's always useful to look at the multi-center experience rather than the single-center experience. But what you'll find is the negative predictive value is high, and in some studies report up to nearly 100%. So it's a very, very reassuring test. Okay, so to summarize that, CT angiography performs best in the non-high-risk patients. And why is that? In high-risk patients, you often have heavy atherosclerotic burdens. And as you'll see, CT angiography, because of technical reasons, because of the limited spatial resolution compared to invasive angiography, tends to overestimate stenosis. So what you will like to try to avoid is doing a non-invasive test that gives you a may be significant, could be significant, as opposed to definitely not significant, because obviously then you're left in a quandary and you have to do more and more tests. One of the important messages that people often fail to understand is no non-invasive test is 100% with regards coronary artery disease. CT angiography is close to it, but if you look at how we traditionally have always managed patients, exercise, treadmill, if that was negative, you would be happy to discharge patients. If they went on to have a stress echo, if your stress echo was negative, you're happy to discharge patients. You have to always ask yourself, what is the specificity and sensitivity? And none of these tests are 100%. So there's always going to be patients that slip through, unfortunately. But CT angiography kind of gives you that added reassurance that you will at least identify patients who have got significant atherosclerosis. So in this data, basically what it does show you is in high-risk patients, because of the problems with the specificity of CT, you often don't change outcomes based on CT angiography. Similarly, in low-risk patients who probably didn't have a significant stenosis, and you could identify that just from taking a history. Again, there's probably no benefit from doing CT angiography, but where it's useful is in the intermediate group. So in other words, the group where they have a few risk factors, the history is a bit atypical, as outlined in NICE, which we'll talk about in a sec. Okay, so CT angiography is often very helpful in patients who present with either atypical chest pain or typical chest pain, and either then a positive or an equivocal exercise test or a negative exercise test where you need that additional reassurance. So then that can be very helpful. And what we'll do is I'll show you some data from the SCOT trial, which basically shows you how you can use CT angiography in the real world. So this basically just shows you that compared to the traditional modalities that we're more comfortable with, SPECT and stress echo, CT angiography doesn't perform any worse. So there was quite a large study fairly recently called the PROMISE study, which tried to compare anatomical testing versus physiological testing. I think the important take-home message was that using an anatomical strategy, i.e. using CT angiography, is not disadvantageous compared to using a physiological strategy. So in other words, if you don't have stress echo, if you don't have stress MR, if you don't have SPECT, you can still have a successful triage system using just anatomical imaging as a gateway to angiography, let's say. Inevitably, how your service develops is all about what resource you've got locally. So you'll see lots of centres where CT angiography demand goes through the roof, are often centres which don't have many physiological tests or have limited access to physiological tests. So for example, we had the challenge at Imperial because we have SPECT, we have stress echo, we have stress MR, and then we had CT angiography, how best to fit that into that algorithm. So where we found great help is in patients, for example, with left bundle branch block, where you know the stress echo is going to be challenging. You think actually the coronary arteries are going to be no significant stenosis, at least from the history, and you just want that added reassurance, and CT angiography performs very well. And obviously in more of the chest pain clinic patients coming through where you think this is, you know, equivocal exercise test, I want to discharge the patient, I can't with an equivocal test, then you can use CT angiography. So that's been helpful. But the bottom line is, if you do use CT angiography alone as opposed to physiological tests, your service is not going to be at any disadvantage compared to physiological testing. Obviously, you have to temper that with what do you do with the intermediate stenoses, but that's a separate problem. Okay, so I've touched on NICE, just to rehearse what NICE says. The first thing NICE says is that you should be using CT angiography in the intermediate group. So in other words, you're not using it in high-risk patients. Although they recommend doing calcium score and a calcium score of 0 and then discharge, that obviously that's a bit more controversial. Taryn will show you data to support that argument. But effectively what NICE is saying is if you have any calcium, and if it's calcium of less than 400, then you should proceed to CT angiography. The 400 is a little bit arbitrary. It's based on a cutoff that shows that you've got an increased risk ratio compared to normal patients. But as you'll see, the more calcium you have on a CT angiogram, the more technically challenging it is to report, and therefore the less likely you are to say no significant stenosis. You'll find in cases where there's lots and lots of calcium, you'll end up, you know, saying moderate stenosis at worst, or at best rather. So in other words, 50 to 70%, which doesn't really help your referrer a great deal, because you're effectively saying, I don't know, needs another test, which is, you know, most people want binary yes, no, rather than maybes. So it's always best to try to skew your patients to those that you can confidently rule out coronary artery stenosis. So the bottom line is, NICE say if you have got a score of more than 400, or if you're at higher risk, then because of the fact that you've got atherosclerosis, almost certainly you're better off with a physiological test. As to whether you adopt that or not, as I said, depends on your local facilities. So ESC have a similar strategy. Again, it's the low to intermediate risk, and obviously they specify where you've got the technology and also the expertise to report. But again, it's often supplemented with physiological tests. AHA basically tell you the same thing. So intermediate risk, often where the ECG is uninterpretable, i.e. left bundle branch block, or for example they can't exercise, then it can be very, very helpful. Now saying that, you can use CT angiography in high-risk patients. We often get patients who, for example, you think have got angina, but they're refusing invasive angiography. So there, what you're doing is effectively trying to identify groups of patients with potentially surgical disease as opposed to medical management disease. It's not ideal, but you can certainly use it. And obviously, for looking at left main stem and proximal LAD, because these vessels are larger, it means it's technically easier to interpret. As vessels get smaller and smaller, because of the limited spatial resolution of CT, remember your CT resolution is 0.5 millimeters at best. Often you're reconstructing at thicker slices, and because of problems from artifact from calcium, it makes it more challenging. You will often, as I say, overestimate stenosis in comparison to higher spatial resolution techniques such as angiography. Yes?
In presence of calcium in the left main, expansion difficult.
I mean, there's 2 points to that. One is when you do a calcium score, the important thing to remember is you're using the Agatston criteria. The Agatston criteria is based on a 3 millimeter slice thickness. Okay, so the way that CT determines the attenuation of a voxel or a pixel is based partly on the slice thickness. So what you'll often see is calcium looks a lot worse on the calcium score than when you look at the CT angiogram, because you've just got better spatial resolutions. That's the first thing to say. Second thing to say is as the vessel gets bigger, then it becomes technically easier because you've got more pixels to deal with. So even if you have got calcium, you often won't struggle to the same amount. So if you think about it, if you've got a millimeter vessel and you've got some calcium in that vessel, you've got 2 pixels to deal with. So, you know, it's going to be almost impossible to rule out a significant stenosis when you've got calcium, whereas left main stem, you're dealing with 6-7 millimeters at least in cross-section. So you're dealing with more pixels, and as you get more pixels, your spatial resolution is better, and therefore you are more confident in your analysis. So although you may have calcium, you will be able to determine it.
There was a study announced this year for the FFR measurement by CT. The CT flow, I don't know if you are aware.
I think Taryn's got a talk on that, because obviously you can apply FFR.
They have announced some results similar to established lesions and find how significant they are by using a special software.
Yeah. I mean, we've got a talk on that, so you'll hear all about that. I mean, again, for those of you who've not heard about it, you can use computational fluid dynamics, which is basically a way of modelling flow, to predict whether the moderate stenosis, i.e. the 50 to 70% stenosis, are flow limiting. And in terms of correlating it with standard FFR, which is fractional flow reserve, which is a traditional measurement that you use in angiography to assess flow limitation across stenoses, it correlates very, very well. So there's a lot of interest in this technique to help you deal with the moderate stenoses, because it's the moderate stenoses where obviously you can't give that binary yes/no answer. Obviously, if you've got no significant stenosis, that makes it a little bit easier. I suppose where it can also be helpful, if you've got to remember in certain vessels, if you've got diffuse atherosclerosis, even though you may not have more than 50%, the extent of atherosclerosis may be sufficient that it can actually cause symptoms. So I suppose you may be able to identify that group. Okay, so going back to SCOT-HEART, which is another very good study. This was basically just looking at how we could use CT angiography in the standard clinic approach. So basically patients were recruited, you do the traditional risk, you take a history, assess their risk factors, put them on the treadmill, and in a subset they then went on to have a CT angiogram kind of blinded to the referrer. And what they found by doing CT angiography, you would potentially at least redefine the diagnosis in about 20% of cases. So in other words, cases where you didn't think this was angina, you would rethink, and versus cases where you thought this is angina to this isn't angina. So that was potentially of use. And also it resulted in less cases going forward to angiography who didn't need angiography. So it's a very nice study and worth having a look at. Okay, so touching now on prognosis, as we've said. Obviously, when you do a CT angiogram, it's not just about is there a significant stenosis or not. You will also get an idea of the overall atherosclerotic burden. And that's obviously very important because you will get patients who've got normal CT angios versus patients who've got diffuse atherosclerosis but without significant stenosis. So what this study showed was that if you can use CT angiography, if you don't have obstructive disease, especially if your CT angio is normal, your event rate is very, very low. So that's very reassuring, in other words. And that's been backed up by data from the CONFORM registry, which basically shows that if you effectively have got a normal CT angiogram, your event rate is going to be very, very low. So that ties in quite nicely with patient management. As you have more and more disease, obviously your prognosis worsens. And there's been a very nice paper recently which showed that if you have got coronary artery disease without a significant stenosis, but in more than four or more coronary segments as defined by the AHA and as per angiography, you've got the same outcome as somebody who has got a significant stenosis. So it really just emphasizes the fact that you should also consider the overall atherosclerotic burden of patients. And one of the things that you need to try to get across in your report is emphasizing, you know, you may say no significant stenosis, but to your referrer that may mean that they don't have significant coronary artery disease. So you want to emphasize whether somebody's got high atherosclerotic burden or not. And that's where calcium score can be useful, because it gives you an objective measure. Everybody in medicine loves a number, don't they? You know, when you say EF of 45%, that is 40, it's got to be 45%. It can't be 41. It can't be. So people forget that there is variability. But the point is, people love numbers in medicine. So if you can put a number to the degree of atherosclerosis, then that's very, very helpful. So what I certainly teach to our juniors is that although people say, well, what's the point of doing a calcium score in addition to a CT angiogram, because, you know, effectively you're going to be looking at the same sort of thing. Just by doing an Agatston score, you can give them this number that relates to outcome and also is a less subjective way of conveying the degree of atherosclerosis. Now, there is another score which is based on this Lehman score, which was originally a score on angiography, which has been modified to CT. And this paper basically shows you that you can use that to effectively be an independent risk factor for outcome in addition to the traditional outcome. So again, another nice paper. Problem with this is obviously it's going to take more time to do the scoring, because you have to look at individual vessels and stuff. So in the research setting it's great, in the clinical setting it can be a bit more tricky. Okay, so one other thing to just touch on, at least now, and you'll hear it again in other lectures, is that you can identify so-called high-risk features on CT angiography as well. Although SCCT and we recommend when you classify plaque, you limit yourself to calcified, non-calcified or mixed, so you avoid the word soft plaque. Yeah? You can identify certain high-risk features. So the so-called high-risk features, so these are features on CT angiography that are associated with patients presenting with unstable symptoms either at the time or at a later date, are things like positive remodeling. So what we mean there is the lumen is preserved and the atherosclerosis is around the vessel. Spotty calcification, so rather than just purely non-calcified or purely calcified plaque, you have these spots of calcification, which is usually less than 3 millimeters. Also, obviously, if you've got lots of atherosclerosis, especially if the plaque is non-calcified. And finally, this thing called the napkin ring sign, which basically means that if you look at these vessels, here's your lumen, you have circumferential atherosclerosis, and then you have a so-called necrotic core. Now, although we use the word necrotic core, CT is not sufficiently robust to distinguish things like fibrous cores from fatty cores from necrotic cores. But if you see this feature where you have circumferential positive remodeling and this area of low attenuation next to the lumen, that's effectively the napkin ring sign, and that's considered a feature of a high-risk plaque. Whether it actually alters your management or not, I'm not entirely sure, because you treat these patients aggressively anyway, but you just need to know that in terms of outcome, they're more likely to have acute events at a later date. Okay, so in summary, using CT in stable chest pain, can use the calcium score, and you can even use it by itself, as you'll hear later on. I don't know, did you do the calcium score talk yesterday? Yeah. Okay, so you know about that already. Obviously, if you're going to be using CT angiography, try to limit yourself to those patients where you can rule out coronary artery or significant coronary artery disease, rather than having to recommend further tests. So in other words, the low to intermediate probability is probably the best group to target. Don't forget that the degree of atherosclerosis on CT angiography is also of prognostic benefit and prognostic importance. So it's always worth conveying that in your reports. And obviously, calcium score, in addition to CT angiography, have this additional prognostic information over and above the traditional risk factors. So moving now to using CT angiography in the so-called acute chest pains. So there's been lots and lots of papers fairly recently trying to look at the role of CT angiography in the emergency department setting. So these are patients who present who you don't think they've got coronary artery disease. Can you do a CT angiogram in these patients, for example, and discharge a group and risk stratify a group that then needs further investigation? A lot of the studies have been based in the US, and what they compare it with is SPECT traditionally, because SPECT is very popular in the US. It's much more popular than stress echo. So a lot of the non-invasive physiological testing in the US is done with SPECT rather than MR or echo. So that's often the gold standard. So if you look at the studies, basically what they've shown is that CT angiography performs as well as SPECT in this acute setting. You can potentially identify other causes, so things like pericarditis, although that can be difficult, dissection. You can potentially discharge patients quicker. Obviously, this has to be balanced against the availability of the technique. What you have to remember, especially if you're not offering CT angiography at the moment, or if you have in a small setting, is often the radiographers panic unless they're used to doing loads of these. So it can be very difficult to offer a 24/7 service, and you've then also got the dilemma of who's going to do the reporting, especially if there's only one or two of you who are doing CT angiography. I think that paradigm will change over time, because I think there's bigger push to integrate CT angiography as more a 24/7 service, and then the registrars will all get trained in it and be able to report them, and obviously get final sign-off, much as any other CT is done at the moment. Okay, but so there's lots of papers, and the bottom line is you get additional prognostic information. You can discharge patients potentially a little bit quicker if you adopt a CT angiography strategy, and obviously there's a big pressure to relieve patients from the emergency department. Okay, so moving now to people with established coronary artery disease. So in stents, we can use CT angiography in stents. Stents behave in a similar way to calcium. Some of the newer stents, because they're thinner struts, because they're different materials, cause less artifact, which means that they're more interpretable. But generally, most people recommend that you shouldn't try to tackle stents of less than 3 millimeters, just because, again, you run into that problem with the spatial resolution issue, and you will not be able to confidently rule out intra-stent restenosis because of artifact associated with the stent. Stents behave in the same way as calcium. So in other words, they block the x-rays and you get beam hardening, and you get photon starvation just deep to the calcium or deep to the stent, and that can look, for all intents and purposes, like intra-stent restenosis. So again, you're not really helping your clinicians by taking things further forward. Where it can be very helpful, and certainly where Taryn uses it and where we started using it, is, for example, in patients who've had stenting of the left main stem or the proximal LAD, which have been very difficult, and the cardiologist wants to make sure that the stent's okay at a later date, even though they may be asymptomatic. So, for example, we've used it in that sort of setting. Okay, what about in bypass patients? So obviously you are acquiring volumetric data, you acquire the whole chest. That means that you should be very good at identifying grafts. So in terms of identifying patent grafts and identifying courses of grafts, CT angiography is very, very useful. And certainly the cardiothoracics always ask for CT angiograms before they do redo stenotomies, because obviously the grafts can lie very close to the sternum and that can impact their surgical route. But also where this can be helpful is, for example, if you don't know whether grafts are patent or not patent, you can confidently identify which grafts are patent and which grafts are not patent, even before angiography. I think one of the things about CT angiography is, as doses are coming down and as people are getting more and more confident, what you'll find is, I suspect in maybe 5-10 years' time, people will have a CT angiogram as a roadmap before angiography. So in other words, so that the interventionalist can plan procedures, can work out who's going to need PCI, who's not going to need PCI, who's going to need FFR, who's not going to need FFR. Because ideally what you don't want is for people to go to the lab, they have an angio, it shows moderate disease, they have to come back for an FFR or some other test. So in other words, if you can kind of streamline the cath lab procedures, then that can be of help. So the bottom line is, CT angiography is very good for grafts. It becomes progressively more difficult with the native vessels, partly because the vessels tend to calcify very heavily after bypass, and obviously then you are left with that challenge. Also, distal vessels tend to be small vessels, so again it can be a bit tricky. Okay, but the bottom line is sensitivity again and specificity for graft occlusion and significant stenosis is very, very high. So in other words, it's a very good test for bypass. And I think in Germany, where they study grafts routinely, I I think they do CT angiography yearly for graft patients. So there is some evidence for that, albeit it's not followed in the UK. So in the UK, we limit ourselves to those with symptoms. Okay, so what about in heart failure? Obviously, if somebody has got what looks to be a non-ischemic DCM, CT angiography can potentially give you added reassurance to that. Obviously, what you want to avoid in those sorts of patients is missing left main stem disease that can present like a DCM. You've got the challenge of what to do with beta blockers in that sort of setting. Saying that, I think I did my best ever CT angiogram in somebody with severe heart failure and a heart rate of 90. I think mostly because his EF was about 5 or 10%. So even though he was tachycardic, the heart actually wasn't moving. So it was a good study. But so you can do it, and obviously you can give beta blockers. And what you may need to do is modify your protocol. So you may just use a retrospective protocol or use systolic phase imaging as opposed to diastolic phase imaging. You can also, and I think Taryn will show you some slides of this, actually look at delayed enhancement. Obviously it's not to the same extent as MR, but it's an option. Looking at valves, you'll hear that CT is now replacing echo and certainly TOE for TAVI assessment. People are getting more and more comfortable with annular measurements based on CT as opposed to any other 3D technique. Remember, if you've done a retrospective study, you are going to be able to do volumetric analysis, and because you're dealing with volumetric data, it means that your volumes tend to be very robust. Also, because there's a big difference between the blood pool and the myocardium, because you've given contrast, it means that the automated softwares work much, much better than the MRI. So in other words, you can confidently work out the ejection fraction, you can confidently work out the volumes. Obviously, you can indirectly calculate severity of valve lesions, not that I'm recommending it, by looking at differences in stroke volume between the left and the right heart. You can use a volumetric method to calculate regurg, but clearly echo is going to be the gold standard of that. One of the things that you'll hear in the TAVI lecture as well is we've sometimes combined CT with echo in cases where the echocardiographer is not sure is this moderate or is this severe stenosis, just by looking at the extent of calcification. The more and more calcification you've got in the aortic valve leaflets, the higher your chance of having a significant stenosis. Obviously sensitivity and specificity is limited, but it can give you that additional bit of information. Okay, so remember, when you do a TAVI study, you're not only getting the coronary, the aortic annulus, you're also getting the peripheral access, which is obviously of great use when you're planning TAVI. What about in arrhythmias? You can modify your protocol to look at the pulmonary veins. Remember, if you're looking specifically at things like the coronary sinus, the way that we time our CT angiograms is based on arterial opacification, so you'll have to modify that. We've certainly used it in the assessment of the left atrial appendage, so in patients who are very elderly who can't undergo TOE easily, where there's a worry that they may have left atrial appendage thrombus, then you can use CT angiography to help you with that question. And sensitivity is very high for that particular problem. What about patients who've already gone to cath lab? I kind of mentioned yesterday that where CT angiography can be helpful is in the visualization of coronary anomalies. You'll hear from the lecture following this that coronary anomalies obviously are not that uncommon and can be very challenging to understand in 3D when you're limiting yourself to two-dimensional pictures, especially when you're not seeing them all the time. So CT is great because A, the surgeons love it because you give them the anatomy, the surface anatomy, they can relate to that. B, you can really see the relationship of the coronary arteries with the various structures. You can also use it in stent planning, so especially in CTOs, so that's chronic total occlusions. So you can identify how much calcium there is, the extent of the occlusion, and also potentially if you can merge your CT data with your cath data, give you an idea of how long the stenosis is. Again, also in left main stem, we've had cases where for whatever reason they've done a cath, they haven't IVUSed the left main stem. There's a question as, is there a significant left main stem stenosis here or not, or is it just a kink? We've managed to do left main stem CT angiography. Can be a bit tricky when there's lots of calcium though, so it's not that easy sometimes. Okay, so this basically is a picture of a coronary anomaly, which you'll hear all about later. So other sorts of situations where you can use CT angio, and certainly where we've used it. So our surgeons now are getting more and more comfortable with using CT angio in cases where they think the coronary arteries are going to be normal, where they're operating, for example, to replace a valve. So, if you've got somebody who's early 40s, otherwise asymptomatic, otherwise well, they're going to be doing a valve replacement. They just want that added reassurance that they're not going to get caught out with the coronary arteries. Before they would have to undergo coronary angiography or some other test, CTO can be very helpful for that. And Taryn's done lots and lots of work on heart transplant patients. In transplant patients, you have to cath them yearly because they have an increased risk of atherosclerosis, accelerated atherosclerosis, and they're asymptomatic. So it's always been a challenge in managing those patients. Okay, you can also use it, I think I mentioned yesterday, in cases of cardiac masses. Remember, many of the masses that you will see will actually be secondaries rather than primaries, so they're going to need a CT anyway, looking for a potential source of primaries. Remember, common sources are things like breast, things like lungs, but they can be from anything. CT, and I would always recommend doing a CT in cases of pericardial disease. So often you'll do an MR, you'll do a CT, and you'll do an echo, and you'll end up doing a cath as well. But CT will really give you a good 3D visualization of the pericardium and also clearly identify calcification, which is of great help. Looking at the aortic root, looking at the thoracic aorta, obviously CT is the gold standard, and similarly in dissection. Whether you choose to then follow patients up with CT is arguable because you can do it with MR, but it's always worth doing one CT just because you get nice volumetric data. The surgeon can appreciate where there's calcification, where there's not calcification. You can obviously get the volumetric data from MR, but you won't get the information as to the calcium, and you won't appreciate the atherosclerosis to the same degree, I would argue. Okay, so that's pretty much it. Does anybody have any questions?